I'm Christoph Kranenmann at the Cleveland Institute in Toronto. I am talking today about the Illuminated surgical Keratoscope, which is a very fancy term for an elegant and practical solution for achieving good lens centration and assistance in placing of toric lenses and other astigmatic corrections. In this case of cataract surgery, you can see how the patient is fixating on the little blinking red light, which identifies the visual axis. The astigmatism marker is centered onto that light, and then I identify the vascular markings at the limbus and place the incision on the steep axis as shown here. It is a combination of 3 rings of white LED lights and a blinking red target fixation light. Advantage is that there's only the one blinking red light which will show the visual axis on the lens within the eye, and that the additional LED lights will help in identify potentially both axis and intensity of astigmatism. The light can be turned on and off as needed. I will usually have it on at the beginning of the case until the completion of the Capsulorhexis, and then turn it off during the phacoemulsification, irrigation, aspiration, and turn it back on for the lens positioning. It's proven to be extremely useful for the centration on particular of multifocal lenses, and also helped with the alignment and the centration of toric intraocular lenses. This on the left is a special fixation device made by Mastel instruments that helps to fixate the eye during the Capsulorhexis process without distorting the cornea and optimizing the view. I found it very useful and I would highly recommend it. It easily attaches to any surgical operating microscope. It is easily transportable and has the ability to be turned on and off as needed during the surgery. During this part of the procedure, I will always turn the fixation light off, for I found it interfered with the ability to visualize the posterior capsule well. This is a very elegant and easy to use device that allows excellent fixation and identification of the visual axis of the patient without any disturbance or interference with the surgical view at the time, and with a very easy setup on virtually any operating microscope. It has greatly improved our ability to center, in particular multifocal intraocular lenses, upon the visual axis, and to place toric intraocular lenses appropriately. At this point, we turn the fixation light back on. We use bimanual irrigation aspiration to position the IOL in the bag, and then instruct the patient to look at the blinking red light. I can only recommend its use and utilization to any and all of you. I must admit that since we've implemented its utilization about 3 months ago, we've found profound improvements in outcomes and patient satisfaction after ocular implant surgery, and have been extremely happy to have been able to utilize it.